So it might surprise you, people working in mental health, you think they'd be the people who are most likely to talk about their experience of mental health problems, their own experience. But actually, that's not the case. So back in 2008, there was a very important book called Breaking the Silence, which spoke to the silence around this topic, that there's actually been for a long time a discourse of them and us. We are the clinicians, we don't have mental health problems, you're the patients, you have the mental health problems. And if you talk about your mental health problem, the fear often is you're going to be seen as one of them, not one of us. And there's lots of fears, as we'll see, around disclosure. So that book was about mental health professionals, and people wrote their own narratives about their own experiences of mental health problems. It was a very powerful thing to do, to publish a book. And there were people from all sorts of backgrounds within mental health, so researchers as well as clinicians. There have been wide surveys as well. So there's been a wide UK survey of medical doctors, for example, and that's to people reported, 60% of people reported they'd had what they describe as a mental illness. So that's 60% of doctors across all specialties, medical doctors. And it is actually a consistent finding that the prevalence of mental health problems is higher amongst medical doctors and amongst mental health professionals than it is amongst the general population. And interestingly, in that survey in 2016 as well, younger doctors were the least likely to disclose. I'm thinking back to Sue and Ruth saying, frankly, my dear, I don't give a damn. You might think, well, the young generation are more likely to disclose, they're maybe more open, but actually that's not what the survey suggested. The article, you probably can't see it here at the bottom, in Canada, a survey again was done on medical doctors' attitudes towards accessing mental health resources, and only 12.5% had disclosed their mental health problem to their own family physician, and under 10% had disclosed it to another healthcare professional. So really low rates of disclosure. And finally, there's a Medscape survey every year of doctors, medical doctors in America. 44% in the latest survey, 2019, reported feeling burnt out, which was defined as long-term unresolvable job stress leading to exhaustion and feeling overwhelmed, cynical, detached from the job, and lacking a sense of personal accomplishment. It's quite an astonishingly high figure. There are also figures reported for actual mental health problems as well, like depression. So, as Sue mentioned, I work as a clinical psychologist and I train clinical psychologists here at UCL. We were interested, my colleagues were interested to find out how common is mental health problems amongst clinical psychologists. So there were two large surveys carried out by my colleagues, one of qualified clinical psychologists and one of trainee clinical psychologists back in 2015. And as you can see, we've got quite a lot of people to respond to these surveys. So 678 clinical psychologists who are qualified responded. 63% of those people reported past or current lived experience. And by lived experience, I mean a significant mental health problem they either had currently or had in the past. And you can see that there are actually quite low rates of having talked about this, having disclosed this to employers, for example, 26%, only 26%, 1 in 4 had talked to their employers about it. 11% had never disclosed, and only 38%, so a lot less than half, had talked to peers or colleagues. Again, amongst trainees, it was a similar picture. A slightly higher, 67% reported having had a significant mental health problem or having one now. 29% said they currently had one. That's almost a third of the people we're training in clinical psychology are saying they have a significant mental health problem. And interestingly, again, disclosure to core staff, so people like me, and or clinical supervisors is much less likely than disclosing to family or friends. If we look at that in a bit more detail amongst qualified psychologists, 11% had disclosed to no one, as I mentioned. 68% had disclosed to a member of their family. Obviously, sometimes that might be of necessity. But 65% had disclosed to friends, but very few to employers and colleagues. So there's a clear preference for talking about this outside in the social sphere, but not at work and not on training. So the surveys also looked at why this might be. So they asked some open questions about why it might be that you're not disclosing your mental health problems. And what was clear is that people were really thinking carefully about whether they should be speaking about this. But there were lots of factors that were barriers to speaking openly. So the biggest barrier was stigma, the fear that the consequences of speaking out might be being judged negatively, reported by 72% of people, and also that it might have a negative impact on their career. And if I talk about this at work, my colleagues are going to find out that, I'm not really able to do this job was quite a common fear. So widely held assumptions that if you're a competent practitioner, you don't have a mental health problem. And this idea of resilience is actually sometimes quite problematic because you might be seen, or people might think they might be seen as not resilient if they talk about mental health problems. Also, it might have a negative impact on their self-image, and a lot of people reported feeling shame about it as well. It's something they have to keep hidden. Looking at training, clinical psychologists in training in particular, they were afraid to be viewed negatively and as incompetent by supervisors and core staff, so they'd also keep it on placement from their clinical supervisor when they're working clinically. And many people also reported hearing disparaging comments about how people with mental health problems were talked about if they were professionals. There was also a perceived lack of support and resources as well. So it seemed like there were lots of costs if you did this. If I talk about my mental health problem, there's going to be lots of disadvantages. But if I keep it quiet, there's more benefits. And there was also they noticed that there was a general silence within the profession about talking about mental health problems within the workforce. And particularly amongst training, there wasn't much consideration given to the potential value of people talking openly about lived experience. And finally, what came out as well, which was quite interesting and a bit unexpected, was that people who were particularly perfectionistic were less likely to talk about their mental health problems. And perfectionism is quite common amongst clinical psychology trainees and doctors. So we're now looking at kind of the extent to which, if we tackle perfectionism, does that lead to people being more open and talking about mental health problems in a helpful way? So what are the implications of this survey? Well, first of all, it's a lot more common than we thought it might be. We do need to encourage more open conversations about lived experience in the workplace, and particularly in training institutions like UCL. And we really need to take it upon ourselves as core staff to challenge stigma within the professions. We also need to support professionals with lived experience and help them think about whether or not to disclose. Particularly having an eye to fitness to practice. If all these people are actually having mental health problems, what impact is that having on their fitness to practice if they're not talking about it at work? It may not be having much impact on it, but it may be, we just don't know. But we really ought to be talking about it given it's our profession. And as I mentioned already, this problematic word resilience at times can be problematic if it's seen as resilient means I cope with everything and I don't have any mental health problems. And finally, promoting well-being in stressful jobs and working conditions, not just at the individual level, but also thinking about the organisational level. What can be done at a systemic level to change things? And I'll talk more about that a bit later. Within the training environment, so particularly training clinical psychologists, obviously we think a lot about client needs. What might be the impact of talking about mental health problem with a client? I'm not going to touch on that today, although I can touch on it with questions if people have them. But the focus is very much on client needs in training, and rightly so. That's what we're there for, to help people. But we do need to remind ourselves that a lot of the people in the room we're training will also be clients, and they will have a dual status. So they'll be service users as well as providers. So we really need to champion a training environment that encourages trainees and trainers to acknowledge their role in pioneering openness and social acceptance of mental health problems. And we really need to think carefully about the value that's in the room of all this lived experience, what we could draw upon within the room of the people we're training. Shortly after the surveys, there was a charter published by the British Psychological Society and the New Savoy Conference, which is a group of organisations in mental health. You won't be able to read this, but essentially it provides for action to support the well-being of psychological professionals. And to support compassionate and sustainable workplaces. And it's a very pragmatic charter, and the research study that I'm going to talk about was actually one of the steps that came out of this charter was based on the charter. Before I talk about that in some detail, I just want to tell you what steps we've taken since those surveys on the training of clinical psychologists here at UCL. So first of all, very early on in the training, the first few weeks, we now use a personal response system. We use something called Mentimeter to ask people anonymously in the room, all the trainees, to say whether they've had or have a mental health problem. To dispel this idea that I'm the only one. Because I think what often happens is people arrive on training And they think, I'm the only one in the room who's got depression, I'm the only one in the room who's had bipolar or whatever it might be. And what's interesting is, pretty consistently, it's over 60% the response rate when we do that exercise, and it quite surprises people, but it also normalises the experience of mental health problems for the trainees. We also provide vignettes of trainees who have struggled on training with mental health problems and make it clear what happens, because I think people are really scared about what happens if I talk about this stuff. Am I going to be sent off to occupational health? Am I going to be stopped from training? Is my career over? And so we give really clear examples of actual trainees who've said they're happy for us to talk about their experience of what's happened to them and support they've had. I think it's fair to say, certainly since I've been there since 2013, we've not yet had someone who's not been able to practice. It's led to not being able to practice. And I think the fear of being told you can't practice is much greater than the actual likelihood of it happening. Some core staff, and this is increasingly happening, including people that come and lecture us from outside, now model openly talking about their own lived experience. So I had a lecturer the other day, and she telephoned me, she said, I'm teaching on this topic, on this disorder, but I've actually had it myself, and I'm wondering if I should talk about that with the trainees. And I really said to her, well, this is up to you, but it'd be really helpful if you did that, and that's certainly what we're trying to do now on the course, to kind of normalise and destigmatise as much as possible. Throughout the training as well, we're really trying to attend to the language we use to try and get away from this them and us, patients and clinicians, and recognise the dual status that I talked about. So I've got a timing coming up, have I? Okay, I better speed up. And we're also repositioning service users. So we were calling them service users and experts by experience, but now we go in and recognise and we say people in the room will also be service users as well. The key piece of research that came out of it, which you can't quite see because it's hidden by the furniture, is the development and evaluation of an intervention to support decisions on disclosure. And this research was carried out as part of the Unit for Stigma Research, which we set up in February 2018, which is headed by our course director, Dr. Katrina Shaw. And if you're on Twitter, you can follow us on Twitter at UCLAS Research. So this was an intervention called Honest, Open, Proud for mental health professionals. And the core value at the heart of it was to help clinicians to decide whether or not to disclose, to support them in that decision. Now, it wasn't geared to make people disclose, and people might make the informed decision that they don't want to disclose, empowered non-disclosure. The intervention is based on an intervention designed by Professor Pat Corrigan in Chicago that was a peer group intervention for people with mental health problems. We thought meeting as a group wouldn't work for clinicians given the amount of stigma I've talked about already. So instead we devised it as a guided self-help intervention. But we wanted to keep that peer support, so we also had a peer forum, an anonymous peer forum that people could go on while they did the intervention. It comprises 3 sessions. First of all, considering the pros and cons of disclosing in some depth, thinking about the different ways you might disclose. So that might be keeping it private or actively broadcasting it, and there's a whole range of ways in which you might disclose. And finally, it helps people to think about how they're going to devise their narrative, what they're going to say about their mental health problems. And it gives a template that you can work through and some examples of work-through templates. And then there's a follow-up session to think about what's happened with your disclosure. So we run the study as a pilot randomized controlled trial. I'm not going to speak to the numbers, partly because of time and partly because it was very underpowered as well. We recruited far fewer people than we thought we would, largely because we couldn't get access to a mailing list that we wanted. So what I'm going to speak to instead is the acceptability and feasibility of the study, looking at the qualitative interviews that were done with participants. So participants reported they found it validating and comprehensive. It increased their confidence in making disclosure-related decisions. They found it useful to help them consider new ways of disclosing, and it reduced their isolation. That was quite a key theme that came out, that people had felt isolated. How long have I got? Sorry. A minute. Okay. The peer forum was a particularly valuable part of the intervention, so it was really important that we had included that. They saw that as a particularly important space to be able to talk about it with other professionals and a very de-shaming and validating forum to go on. There's lots of lovely quotes about how helpful the guide was, which I won't read to you because I haven't got time, so I've been told I've got a minute. There are also some very helpful quotes about the peer forum, largely around the idea that this was now a chance to have a conversation finally within our profession about mental health problems. What we noticed, though, is that some people didn't disclose. We thought more people might disclose than they did, and we think that's because they rightly saw the system as maybe not welcoming the disclosure. So we've now changed our research, and we're moving more into compassionate interventions for working with the system and thinking about how the system can respond more compassionately to disclosure. And there's some good changes going on. So there was a report from the NHS Staff and Learners Mental Wellbeing Commission, which I went to give evidence to with my colleague Katrina Shaw. They published a report in February 2019 with recommendations about how to increase mental health wellbeing amongst all professions within the NHS, clinical professionals. I will speak now about where next for you rather than talking about what else we're doing, because I've got about 30 seconds or less. What I'd like you to think about from what I'm talking about, I focused on clinical psychology. I hope this helps to normalise mental health problems, not just for clinical psychology, but elsewhere. I'd like you to think about how you as an individual talk about mental health problems within your context. What narratives and conversations are there within your system about mental health problems, lived experience, burnout, resilience, and what impact do those have? And what could be done to change any unhelpful narratives or conversations? So what might help break that silence that I talked about at the beginning and encourage openness? And also to start thinking about how might I and my colleagues make a more compassionate work culture where these things can be talked about more openly, so that maybe the stuff on the anti-CV can eventually get to the CV and we can all be a bit more open. I would just like to thank my colleagues as well who've all been working on this project. It's obviously a team effort and there's quite a number of them. So I'll put their names over there. Okay.